So I'm slightly the surprise presenter because you didn't expect me, and to be perfectly honest, I didn't quite expect me either. Although I must...
You agreed yesterday.
I did, 10 minutes ago. However, I have had the privilege of working with this team before on this issue, and I'm very committed to the idea of the compass and of helping patients and informal providers find better ways for navigating their way around the health information system. And I'd like to say also that together with Catherine and some other people, we're exploring using this also for, in another setting, for the benefit of standards developers, because we think it's very important to think of the idea of a compass not only as something where you can help find your own direction, but also where you can orientate yourself compared to other people. So, if you like, put yourself in their shoes so that you can better understand what it is that they're looking for. And we think in the context of the e-Standards project that it's really important that SDO, Standards Development Organizations, understand the perspective of the patient or the perspective of the care provider as well. So we're playing with this idea of the compass at the same time. Am I just moving on to the next one? Okay. There's no more slides with details. You just want me to talk about these points? Okay. Yeah, absolutely. So in terms of the ethical aspect, well, let me start off first, as I'm going to now talk just to make it up as I go along, but of course not really. The first thing I'd like to say is that in terms of data ownership, we're in a interesting phase at the moment. Anne put up earlier on the new data protection regulation. One important word in that, regulation. It's a regulation that means it now, thank you, applies across all the European Union countries. It's no longer a directive. That means that we, in theory, will no longer have a lot of variation between countries as to what health data are, how you obtain consent for them, how you store them, and who can access them and how they can be accessed. I say in theory because actually within that regulation there's a huge amount of delegated legislation. There's a huge amount of opportunity for member states to bring in their own variation. And so far we haven't seen very much of this in terms of medical care provision, but we are already seeing it in terms of medical research. And we have to be very conscious of this. So let me just give you a quick overview of what the GDPR says, the General Data Protection Regulation. As Anne already mentioned, it says that everybody has a right to access their data in a digital form and to portability of that data. That means that they can take it and give it to another person for opinion. That's really important within our context here. It also says that only a reasonable amount may be charged for extracting data from, say, a large database and giving it to a patient for their own use. We should note that the right to be forgotten, which is much talked about, does not apply to health data. We cannot demand that our health records be deleted unless we can show that there is a mistake in them. So don't be misled by the idea that the right to be forgotten now applies uniformly to healthcare. It can't be used to disrupt your own medical record, and it can't be used to disrupt research, although again there are variations country by country. What this then sets up, the GDPR, is a new notion of health data stewardship. And the word stewardship doesn't appear in the legislation. It's something that I use a lot and that the people that I work with use. And we use it very intentionally to get away from the word ownership. The concept of data ownership is a very complicated notion. And it's particularly complicated in the healthcare setting, because if you think about your healthcare record, who rightfully has an ownership in that? Do you think it's the patient? Do you think you as a patient have a right to own your record? what is your record about? What does it actually record? Does it record only your health? I would say it doesn't record only your health. In fact, it contains at least 2 and possibly 3 important elements. The fact that you have a health record creates a record not only about you, but also about the healthcare practitioner. So saying that you have a sole ownership in it is complicated, because in creating the record, the healthcare practitioner, be that a nurse or a doctor, a specialist, whoever it is, has recorded the fact that they have treated you, tested you, done something to you. So it's a record about them. To some extent, it is also a record about your friend, your children, certainly, and possibly other people in your family. Because we know that one of the biggest predictors of your health is your genetics and also your social environment. If I'm a child and I live in a family with heavy smokers, with a lot of respiratory health problems, even if I am not genetically predisposed to having respiratory problems, it is likely that I will have them. So that record becomes a record also about me as a child living in that family, whether I'm a genetic child or simply a child living within the family. So for this reason, I think saying blanket, we own our health data, is not helpful. And that's why I'm far more interested in the idea of stewardship, in the idea of saying that my health record and my health data are a very important piece of information, and it is important that it is well looked after and that the right people can access it at the right time, and that we can exploit it also for the common good, so that we do have a notion. We've talked a lot about big data at this conference, about being able to exploit the big data of health records for the common good. But the notion of stewardship is less appealing, and it sounds a little bit less safe than ownership. If we talk about ownership, we can say it's mine, we can put a wall around it, we can say keep out. Stewardship requires education, and it requires the notion of a compass. Because stewardship is far more linked to moral behavior as well as legal behavior, we far more need the concept of a compass that will help us direct ourselves and orient ourselves. So that's why it says health data stewardship there. And this is one of the reasons why we think the compass is so important. That leads me also onto the point of the health data donor, and I alluded to that just now when I talked about the role of big data. I don't know how many of you were able to listen to John Crawford's speech last night, but in his 7 big predictions for the future of healthcare, he talked particularly about the growing concept of predictable population health based upon big data sets that are available, so that we can better tailor the care of the individual based on the context of where they sit in the social environment. So to go back to my comment about the child who is living in a environment with pollution, smoke and respiratory illness, knowing that, having that bigger data allows us to better target the care for that child. And for that reason, I think, again, we need to understand the concept of the stewardship of my data as a good citizen, as a public good, which I have a particular interest in, and which I have a particular set of rights in, but which I also have, to some extent, a duty to share for the public good. We're familiar, at least in Europe, with the concept of taxation for the public good when it comes to money, but we're not very good with the idea of taxation of certain intellectual properties for the public good. And I would posit the idea that actually sharing healthcare data is a little bit related to the idea of taxation for the public good. It's a taxation It's a giving back to the system of what we get from the healthcare system. Now, I realise this is slightly controversial, and nobody ever likes to hear the word taxation. So in another circle, I would perhaps not use the word taxation because it raises negative thoughts. But I wanted to share that idea with you, the idea that it is a common good and that we as citizens benefiting from, for example, the herd immunities of vaccinations, have a duty to give something back in the shape of sharing our data. However, as Anne has already said, the driver of all this is trust, and the speed of change is trust. So we need to build tools to build trust, and the Compass is part of that concept of a tool to build trust. It's not the end of the story. It's simply one of the things that we have in our toolbox to build trust. But it is crucial that we build the trust and build it fast, because the speed of trust will dictate to a significant extent the speed of adoption. And we need to start adopting eHealth. We need to stop reporting projects and start reporting reality. Thank you.